The broadcast is now starting. All attendees are in listen-only mode.
This is Danny Bobrow, President of AIM Dental Marketing, welcoming you to this installment of the Practice Perfection Web-Based Education Series. Today's presentation is entitled, Know Your ROH, that is, Return on Hygiene. As founder of Inspired Hygiene, Rachel Wall, RDH, BS, inspires dental teams to improve their hygiene services and systems while increasing profitability. Drawing from her 25 years of experience as a clinical hygienist and hygiene profitability coach, Rachel delivers to-the-point articles and, as you will soon see and hear, dynamic and informative speaking programs too. She has spoken for numerous major dental meeting venues, including the Yankee Dental Congress, ADA, and Hinman. She received the 2012 Dental Excellence Award from drbicuspid.com for Most Effective Dental Hygienist Educator and was named one of the top 25 women in dentistry by Dental Products Report magazine. Rachel's core belief and the premise of this presentation is that nearly every hygiene team has the potential to do more good for more patients. Rachel reveals areas in the hygiene department that can be enhanced, refined, and further developed to realize a strong ROH for patients, hygienists, and of course the practice. I've known Rachel for years, and actually right before we got on, she reminded me where we met, and that was at an ADOM meeting. I'm not even sure how long ago that was. I guess I maybe blocked it out, but it's been a little while, and I always look forward to reading her social media posts and viewing her informative videos and, of course, hearing her speak. And that's why I'm really pleased and excited that she agreed to join us today. Now, before we hear from Rachel, I do want to remind you that Practice Perfection webcasts run for 90 minutes. While attendees are in listen-only mode, we invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get your questions answered. If we should not get to your question during the webcast, we will see that they're answered shortly thereafter. Attendance at this presentation entitles you to receive 1.5 hours of continuing education credit. Shortly following the webcast, you will be emailed a brief survey with instructions on how to receive your CE. Participants are cautioned about the dangers of incorporating techniques and procedures into their practices if the course has not provided them with adequate clinical experience to allow them to perform it competently. And with that, it is my sincere pleasure to welcome to the Practice Perfection stage my good friend Rachel Wall. Hello, Rachel.
Hello. Thank you, Danny. Thanks. It's a pleasure to be here. I appreciate you inviting me. And yes, it was at ADOM, and I think it was probably about 5 or 6 years ago. Seems like even longer than that, but you know, time flies when you're having fun.
Well, these days, when I think it's 5 years, it's 10 years. So
yeah, exactly. I know the feeling. So you probably noticed, Danny, you had a chance to see this photograph ahead of time, and you can tell by the thumbtack holes that this photo has been on many a corkboard over the years. And I really cherish this photo, and you picked up right away why that is, and all of you watching can probably see the obvious reasons why I cherish this photo. But the thing that you might not know is that in addition to this fabulous trip to New York City, this also reminds me of the time that I worked with these amazing dentists. And so these 3 ladies that are standing here with me, I had the privilege of working with them for probably a total of about 6 years over some period of time, and this was probably taken in about 1995. And you know, this was a trip that we had the experience as a team, and we were there visiting a dental lab, and the dentist didn't just take, you know, the dentist and the key assistants. They brought the whole team. And you know, I was listening to a podcast that Howard Ferran did recently. In fact, he says this about every other podcast, is that he has found that the most successful dentists are the ones that don't necessarily come by themselves to a CE or send one person from their office to the CE, but they really bring everybody. And I have to say that I have found that to be true as well, and that was certainly true in this practice. And so, you know, these dentists didn't just invest in us, the team, through compensation and CE opportunities. They also invested their time and their expertise their patients and their willingness to lovingly but firmly push me beyond my comfort zone. And during my time there, I was exposed to some very powerful personal and career development tools, and I can honestly say it is a huge part of why I get to do what I do today. And they invested in me, and I personally got a huge return having the privilege to work in that practice. And my patients also got a strong return. You know, they had providers that were continually learning to deliver better care, communicate more effectively, make them more comfortable. And I'd like to think that these doctors and the practice got a strong return for their investment in me as I worked really hard to help build that practice and be a part of a strong, growing hygiene department. And that's really what ROH is all about. You know, so you've heard, everybody's heard the concept of ROI. So this is a little play on the words. And what I really believe is that our investment in our education and the effort that we put forward to refine and enhance and develop, you know, the hygiene department really should have a return not just for the practice, but first for the patient, and then next for the provider as well, right? I grew professionally being in that environment. And then obviously when I'm performing at my best, then it helps build the practice. And so that's really what this program is going to be about. And we're going to take a couple opportunities throughout the next, you know, hour or so to really look at some of the things that we talk about and have you ask yourself, you know, what is the return? If I do this and if I make these refinements to my skills and the way I communicate, what is the return for the patient? What do they get? What does the practice get, and what do you get as the provider? And I want you to really kind of think about that as we're going through this. So if we think of hygiene as the backbone of the practice, which we hear so often, is you know, that spine that you see here, right? This backbone, it has to be really strong, and there are a lot of different systems that are involved keeping that in place. And so what we believe is if the hygiene is going to be the backbone of the practice, a few things need to be true. And there are a few stats that are important to know. We're going to talk about these just right off the bat here. One is, the first stat is that for a hygiene department to be bringing profit into the practice, they have to be producing at least 3 times compensation. And that allows us to get to that first point of profitability. And we're going to talk about that in a little bit more detail in just a few minutes. The next thing that we look at and we love to see is a hygiene department that is extremely Perio aware. And not every practice is going to hit 35% Perio. Some practices are going to greatly exceed that. But that's one of the benchmarks that we typically see when there's a real strong Perio awareness and really clear systems and great enrollment skills around periodontal therapy, is that they start to get in this 30-35% range with their Perio procedures. And again, we'll talk about all of these in a lot more detail this evening. And then 60%. So there's a lot of stats from a lot of different consultants that say that at least 60% of restorative should be enrolled in hygiene. And that is a combination effort of the hygienist and the doctor, and the two of them really being on the same page and being calibrated and having great communication skills between the two of them and also with the patient. And then 10%. This is really the top end of the open time. You know, open time is one of the things that we hear a lot of practices struggling with right now is open time. And so 10% of your time being open is really the top end of that, and we'll talk about that a bit too. So these are areas that we'll address this evening, and I'd like you to really think about maybe where you are with these, and I'm going to give you some tools to find out more about that in your practice. So I always like to ask this question: is what is your hygiene philosophy? And so whether you are a dentist, a dental assistant, someone on the business team, the practice administrator or hygienist, you have some belief about how the hygiene department should serve your patients in your practice and how those group of people should represent your practice in the community, how you should be caring for your patients, and also how you provide teamwork within the practice, how the hygiene department interacts with the rest of the practice. And so I always like to challenge folks to kind of write that down, you know, so maybe that's a piece of homework for you, is to write down what is your hygiene philosophy. Is it that you want to identify disease early and have a proactive approach to care? Is it that you want, first and foremost, to make sure your patients are comfortable and that they feel cared for in your practice? Is it that you want your hygienists to be cutting edge and to be super efficient and to be super knowledgeable about all of the products and the materials and things that you're using in your practice? What is your philosophy there? And then what I would ask you to look at your philosophy and see how these statistics match up with that, right? These statistics are a gauge. They're a way for us to measure some of the intangible things that happen in the practice. And so look at your stats. Are your stats lining up with your hygiene philosophy? And you may not know. You may not know yet if they do, and so that's why we like to ask, well, where are you now, right? Because before we can strive to get to the next level in anything, we need to know where we are now and where to best focus our energy to get that desired result. All right, so let's start at the foundation, and let's look at those stats and how we might find out a little bit more about that. So you'll notice in the dashboard of the meeting here, under the questions section, that there's a handout, and I'm going to ask you, rather than downloading that now, I'm going to ask you to maybe wait until a little later in the program to download that handout. I'm going to show it to you now so you can see really what it is. This is
if anybody has trouble finding that, excuse me, Rachel, I'm sorry.
Sure, it's okay.
It's on your menu on your dashboard. Under the questions tab, you should see a plus sign followed by handouts, 1 of 5. Anytime you like during the webcast, you might want to do it sooner rather than later. Simply expand that and choose to download it to whatever part of your computer you'd like, and it'll be there for you to then communicate with Rachel. Sorry about that.
That's okay. Thank you, Danny. So this is a PDF. This is an interactive PDF, and so you'll download this, and it'll look like this when you first download it, and you'll see these blue boxes. So these blue boxes are where you're then going to enter information. And this can be for you, just for your own information. I would love for you to share this with me. You can email it to me at rachel@inspiredhygiene.com. I'd love to have a call with you about it and just give you some thoughts on your stats. I'd be happy to do that. So this is what it's going to look like when you download it. And then as you enter your numbers, you're going to see these under where it says your hygiene stats. You're going to see those numbers start to populate. So it's going to start to tell you where are you in the profitability ratio. What is hygiene's total percentage of total production? What's your open time? What is your Perio percentage? It's going to give you some of these stats that we're going to talk about tonight through the course. And all you have to do is print a report from your software and plug those numbers in here into these blue boxes, and it'll crank this right out for you. So it's just a great way to kind of find out where you are now and where you might see some opportunity to improve. And what it shows is it just shows kind of some standard industry benchmarks that you can kind of compare where you are to that and give you kind of a starting point there. So it's always good to find out where are we now. So let's just always joke and say, let's start with the money conversation and get that over with. This is probably the topic that makes folks the most uncomfortable and creates tension sometimes in teams when they're implementing new services. Doctors struggle sometimes with their team thinking, well, they just want to increase services and have us do more because it's more production. But really, I just love talking with doctors that say, these stats are what got my attention, but really I just want to make sure we're doing the best thing for our patients. And that's really what I feel like the vast majority of our industry really focuses on first, is how do we deliver the best care, and then we get these, financial results. And we've all heard it before, dental practice is a business, and we all have rent or a mortgage to pay, and probably 2 or 4-legged family members that depend on us to, eat and have a place to live. And so we all do have to, make a living. And the dentist takes a lot of risk in opening up a practice, with loans and leases and liabilities and responsibility. And so there should be fair market salaries for the team, and there should be opportunities for the team to grow their income, I believe. And then there should also be profit for the practice and for the doctor, right, for taking all that risk. And what I found as a business owner, I can say that, most of the time that profit does not necessarily go into the business owner's pocket. It usually goes into reinvesting in CE and new equipment and things like that. So we look at this image here, and we kind of have these areas categorized by, 1/3 of that net production can go to salary and benefits. 1/3 is for the overhead of the hygiene department, right? So this is supplies. This is the lease on the equipment. This is replacing instruments, things like that, right? That's hygiene overhead. And then that last section can come from profit if you've hit that 3-to-1 ratio. And this is something that if you've ever investigated this or looked at this, you've probably heard that before. The 3X or the 3-to-1, we call it, is that first point of profitability. So if you're at 2-to-1, so if hygiene is producing 2 times compensation, then you're probably not seeing any of that profit or very little of that profit coming from hygiene. And so it's important to know a couple things. One is that when we're making this measurement, that it should be made with net production, right? We can't pay out what we don't collect. And so make sure that when you're running these numbers that you're using net production, and that you're fairly communicating that with your staff too. And sometimes we've had teams that have gone from fee to service to participating in some plans. And so that is something that requires a conversation, right? And having the business owners explain to the team why it's time to do that and how that's going to benefit the practice, particularly if there have been compensation or bonuses or things like that that are based on production. So this is just an easy way to look at this. If hygiene total compensation were to be $75K a year, you multiply that by 3, and so your first point of profitability is when they're hitting that 225. So if you're going over that, then awesome, right? You've got even more than that first point of profitability. And if you're under that, then it's a good time to look and see, okay, what can we do to improve that would also improve the health of our patients? So we get questions a lot of times about hygiene compensation and how to create systems that make it interesting for the hygienist too. And also support teamwork. That's the biggest thing, right? We don't ever want to have a plan that's in place that really tears the team apart. And I always love this slide because here's the deal, is that it's not about the money. I mean, we all have to make a living, but we all went into this profession to make a difference and to have the opportunity to work with our patients side by side and work with a great team. So, when we work with our clients in Inspired Hygiene, they create dramatic increases in the value that they're delivering to their patients. And very often the byproduct of that is also a dramatic increase in their profitability. And that production, those numbers, those stats are really a measuring stick for the amount of value that you're providing. And so just remember that, and just keep in mind that there are a lot of intangibles that we can't measure. A lot of times I ask, when I'm in a live audience, I'll say, what are some of the characteristics of a great successful hygiene department? A lot of times folks will say, they have great rapport with their patients and patients trust them. And that absolutely is one of those statistics that's hard to measure, but when we look at these other things, they are a gauge even for some of those intangibles. So let's look at some other ways where we can measure our effectiveness as dental providers and see where we might have some potential to refine our systems and take it to the next level. So the one that always comes up for us first, right, is our Perio Awareness. And this is a tool, Danny, that we developed several years ago. Again, this is also an interactive PDF that you can get at our website here at the top, that you can plug in some numbers from your procedure reports and you can see, where do you stand in regards to that 30-35% that we talked about in the Perio percentage. And this is actually a great example. This is a real client rather, and this is a great example of how a practice, if you look down here and you see this 45%, how they can be at a really high Perio percentage. But then if you look up here, this is for a year's time, and you see that in a year's time they only performed about 41 quadrants of periotherapy. So, if we divide that by 12 months, that's only nearly 4 quads a month, And even for one hygienist, that's a pretty low number. So this is a really great example of, we work with teams all across the board that are just getting a Perio program started in their practice, or they've been trying to get that done and just haven't been able to get any traction in that area and get the team on the same page. And then also teams that have been doing this for a while, but maybe now their patients have shifted from prophies into perio maintenance, and they're not sure how to get them back, re-enrolled in active therapy when they're having relapse of disease. So just an interesting example of how a team can have a high number but still have some opportunity to grow in this area. So let's look at, I believe what it takes is to do all the things that hygienists are asked to do now in an appointment. We believe that for the most part, that 60 minutes should be the standard for recare patients, whether it's an adult prophy or perio maintenance. Now, we have clients that have customized scheduling, and that can work really well as long as we've got some core beliefs very well established in how we use our time. And so I always love to ask audiences, what do you think your patients believe is the most important part of the hygiene visit? And what do you, Danny, if you're there and available, what do you think teams say their patients think is the most important part of the hygiene?
I'm here. I would imagine that the feeling and the more tangible, it would be the prophy.
Yeah, and that's what 99% of audiences say, right? And then I ask, okay, so for us, especially hygienists, what do we believe is the most important part? And sometimes they'll say the scale and polish because I'm disrupting the biofilm, and they absolutely get some value in that. And then some will say, well, really the hygiene exam. And that's what I believe. I believe that's really the most important part of this visit. And I do believe, too, that if we can even slowly step more fully into our role as healthcare provider, that I think we can bring our patients alongside us there and help them see the value in that hygiene exam too. And even if it's just every visit there's one little thing, it's not something that's necessarily going to be a huge shift all the time, but even if we can give them one glimpse into how their dental care is going to affect their overall health, I think that can make a big difference. And so we talk about this, we call this the 20-20-20. And I go into this in a lot more detail in a longer course. But if you look at that hygiene exam, what happens in that hygiene exam affects everything else that happens in the practice. And so think about it, is that hygiene exam is the time for the oral cancer screening. That's the time for intral photos, radiographs, a complete perio evaluation, a restorative evaluation. So we say, okay, imagine if the hygienist is not able to do, maybe he or she doesn't have 60 minutes, and so maybe they have decided for whatever reason that the perio exam is the thing that's going to have to be left out. So now all of a sudden that patient, the hygienist is working really hard to get that prophy done because they haven't had a chance to identify periodontal disease. And so maybe they're running over, or maybe it's difficult and there's a lot of bleeding. And now if they're running over, the next patient is sitting in the reception area and is staring at the business team. So now all of a sudden it's affecting the business team, right? And they're running behind. And then another patient that we haven't had a chance to do a clear perio diagnosis is in the doctor's chair, and doctor and assistant are doing a crown prep. And that tissue's not healthy. And so now all of a sudden they're bleeding, and it's taking a lot longer to get a good margin and get a great impression. And now doctor and assistant's running over, right? And so then all of a sudden, guess who calls for a hygiene exam, right? So hygienist is running over, doctor's running over, next patient is staring at the person, at the front desk, and now me as a hygienist, I'm now calling for the hygiene, the doctor exam, and everybody's running over and it's frustrated. And we look at that first 20 minutes. If we could dedicate that and really get all that data and that diagnostic data collected and interpreted, a lot of those issues would be resolved. And not only that, the patient would have the opportunity to be a lot healthier. So it's really interesting if you think about it, all the trickle-down effects of what happens in that first 20 minutes. So
yeah, it's very much like whatever team analogy you want to use. You got the people get you on base, and then other people drive it home. To me, this can only lead to greater treatment acceptance, because it's not just an opportunity to impart information, but it's also an opportunity to impart caring and to sort of set the mood for the rest of the visit, the exam, when the dentist comes in and does the diagnosis. Now he's equipped with a lot of information that the hygienist is able to provide. So
so
see it's all linked.
Yep, and then all of a sudden, doctor's exam becomes more efficient, right? When hygienist has collected all that information, then dentist steps in, and then he or she can just really be very cued in on what they need to focus on and make that very efficient and have more time for connecting with the patient. So just to kind of summarize that ultimate hygiene exam is we really believe this is the most important part of that visit, because that's where we really set the tone for that appointment, and we really get to determine what is in the patient's best interest for today and for future appointments. We also recommend that all of that data collection and everything occurs before we pick up a scaler, because scaling is one of those things that can expand to fit the time that is allowed. And so if at 6 minutes we're starting scaling, then we probably haven't had a lot of time to do the restorative evaluation and photos and Perio, charting and all of that. And so, sometimes we say, well, I got to get my scaling started because I've got to get that finished, and then if I have time, I'll do the Perio eval. But really, it should be the other way around, because the Perio evaluation is going to tell us what it is that's in our patient's best interest today, and really help us determine how much scaling am I doing today versus what is more appropriate for them to come back for a different therapy. So really, always completing all of that before scaling, and also really being prepared, right? So taking some time to look at the patient's chart ahead of time and see, what have we discussed with them in the past? What have we talked about periodontal disease or bleeding or things like that in the past? And just really being, what's their medical history? What am I looking for today that's going to help me really be more of a healthcare provider and be really tuned in with that patient? So when we talk about taking the Perio program in your practice to the next level, it has to start with a why. It has to start with a really strong set of beliefs around that and around our ability to impact our patients' overall health. And these beliefs plus the systems, right, that you have in place, and that allows you to take action, and that's what gets you the results. So if any of those pieces are missing, right, we can just come in and say, okay, so here's your system for enrolling more Perio, and then you're going to start Monday, and you're going to take action by doing a Perio chart on every patient, and you're going to say this or that. But if we as coaches have not helped the team really establish a strong belief system around why that's even important, why is it even necessary for me to change anything that I'm doing about how I talk to my patients or about my exam, then we really haven't done our job, and those systems and that action typically don't stay in place, right? Because if we've got a struggle on the inside, a struggle on the inside always creates a struggle on the outside. So if there's something that we're not quite sure if we believe in, or I'm not quite sure if this is in my patient's best interest, but I know I'm supposed to be doing this because it increases my production, it eventually creates a struggle on the outside. So we might do it for a little while, and then, but all of a sudden we're going to find reasons not to, because we can't maintain that same sense, that state of imbalance. So the example that I like to use is fluoride therapy, for example, right, is consultants, a lot of us are guilty of, we'll say, gosh, if we can just do a few more fluoride therapies a day, we can get to our goal, and then everything will be great. Well, that lasts for a little while, but we really got to go back and say, okay, first let's talk about why is that in our patient's best interest? Who's going to be helped the most by that type of therapy? All right, so let's develop the belief, and then let's develop the system and the way that we implement it. So the AAP is our really kind of our, here we go. The AAP is our kind of base of knowledge right around periodontal classification and what constitutes periodontal disease. And so I wanted to just show you this. This is their website, perio.org. A lot of folks aren't aware of this, but it's a really great website. And what they have here under, if you go to publications, AAP Clinical and Scientific Papers, you'll see here the second bullet point. They recently, last year, they did an update of the 1999 classification of periodontal diseases and conditions. And so they gave us a bit of an update. They made it actually a little bit easier for us. And they told us that, you know, clinical attachment loss is a really difficult thing to measure. And we were like, well, yes, we already knew that. But it was nice for that to be acknowledged. And what they did is they allowed us to now use some of the pocket depths. We had to kind of make interpretations in the past, but now they put it out there for us a lot clearer. And so this is really how the AAP defines these different levels of periodontal disease, right? We call this early or beginning periodontal diseases is really the 4 millimeter range with bleeding and with bone loss, right? Even that crestal bone loss. I'll show you an example of that in a moment. And then moderate is, you know, we're getting to the 5 to 6 millimeter pockets. Again, remember, bleeding is our sign of active infection, right? That is our primary indicator of active disease is bleeding. And then more bone loss, and then severe is 7+ millimeters bleeding and even more bone loss. So it's important for us to know that and have that as a benchmark. And I'm going to ask you a question in just a second that I want you to really think about. So here, this is just kind of an easier table to look at that through. I'll give you just a second to view this. Okay, so let's look at a patient that has beginning periodontal disease. And I want to fast forward here and just look at the pocket depth. Now this is probably pretty small, but you'll notice if we look at the depth here, this is a 4, 4, 4, 4. We've got some bleeding here. This patient was a heavy smoker. She's very young. She was 29, I believe, at the time. She was a heavy smoker, so she didn't have a lot of bleeding, but she had quite a few 4 millimeter pocket depths, and the tissue was extremely tender. So I'm not seeing anything over 4. This is a patient, Danny, you and I talked about this. This is one that would very often move right into or stay in a prophy. When in reality, if we look at this patient and we look at the amount of bone loss that she has, it is significant. I mean, I would call this moderate, right? We're seeing loss of this crestal bone here, obvious loss of horizontal bone loss here, loss of crestal bone. We're starting to see this cupping here, right, between number 29 and 30. A lot of this bone loss, we can see some radiographic calculus here also, right? So periodontal disease doesn't always require calculus, but it happens to be on this one that this is present. So my point of showing this is it's just important for us to really closely look at all the layers of diagnosis here and make sure that we're looking at everything that we're presented with as we're making treatment decisions for our patients. And so this patient has very obvious beginning periodontal disease. And what we know from the AAP, and the ADA also says this, is that conventionally read radiographs routinely underestimate the amount of bone loss. And that really 30 to 50% of bone must be lost, bone density must be lost before we can ever see it on the x-ray. So just keep that in mind as you're reading x-rays and you're looking at that bone loss and looking at what it is that you're being presented with. This is another cool tool. This is a camera called the SoPro Care by Acteon, and intraoral photographs are becoming more and more important, not just with restorative but with perio, for us to really document the disease state and the inflammation. And so this is just a cool tool that happens to have what's called a perio mode. And so you can put the camera in this perio mode and it'll show this magenta area of inflammation, and just a great documentation tool and great tracking tool you know, to use for when you're reporting this to third parties and when you're just sharing it with patients. So if we believe the AAP's research that 47% of adults have some form of periodontal disease, then I would like for you guys to all ask yourselves this question. and I would like for you to find a place in your notes and really write this down, is if we look at that definition that the AAP gives us of active periodontal disease, right, 4 millimeters or deeper with bleeding and even some bone loss, I would ask you to write down, this is just going to be a guess, but just write it down, what percentage of your new adult patients that you see fall into that category. 4 millimeters or deeper, bleeding, and some bone loss, even crestal bone loss. Okay, so write that number down. What percentage of adult new patients? And then the next question is what percentage of your existing patients in recare? So these are adults that are routinely coming in for prophy or perio maintenance. 4 millimeters or deeper with bleeding and bone loss. And write that number down. And then what I'd like you to do is compare that. Compare that to that perio percentage. And I'll tell you, we have a lot of teams that say 80%. 80% of our new and existing patients fall into that category. And then some teams will say 20%. So it's going to depend, on you, but just make that guess and then look and see where are we, how much, what is our perio percentage and how close is it tracking to that. And it's not an exact apples to apples comparison, but it's enough to see if we feel that 60% of our existing patients fall into at least that beginning perio category and our perio percentage is 10%, then you've got a gap there, you've got some potential there to grow. So if that is the case, and a lot of those existing patients are exhibiting signs of active periodontal disease and the perio percentage is not really matching that, then that's a lot of times the reason why we get stuck in this, what I call the prophy trap. And this is the trap of not having, or maybe not making the time or having the time to identify active periodontal disease. And so then the prophies just get harder and harder, and then we have less and less time to do the diagnostic, and at some point we have to kind of call a timeout. We have to call a timeout and say, okay, we've got to come up with another system. And a lot of times doctors will call and say, Rachel, we really need help with this, and I'm worried that my hygienists are going to be resistant or they're going to be nervous about these changes that we're asking them to make. And I say, you know what, ask them. Because a lot of times hygienists are frustrated with seeing all these bloody prophies and not really knowing how to change that. And so when we stay on that prophy trap wheel long enough, that's one of the things that leads to burnout. And a lot of hygienists feel that. They feel like, I'm just running through the schedule. I know I have felt that in the past, that they feel like I'm just running through the schedule and it's not meaningful, and I feel like maybe I'm not getting anywhere. So really look at that. Look at are you on that prophy trap, and is there some potential to grow there? And so I like to just go back to why we started this in the first place, right? You care, and that can't change. I remember these two teams, we do a Perio webinar series, and we had these two teams heard the same exact message from the same people during the same time period, and one team said, okay, so we've heard this, and we believe that taking our perio program to the next level is in our patients' best interest, and we can't not tell them they have active infection. And so we've come up with a plan, we've blocked out our schedule, we've implemented all these things to move this forward. And then the other team said, I don't think we can tell our patients this. And they trust us. The other team said the same thing. They said we think of our patients as family and they trust us. We can't not tell them they have disease. And then the same thing came out of this other team and said, our patients trust us. We think of them as family, and we can't tell them they have active disease. They're going to think we're trying to sell them something. And it really came down from the doctor. The doctor wasn't ready to have some different conversations. And we even give them, ideas of how to have those conversations and confidence that we've seen this turn around. So it really depends on your mindset and your willingness to really get out of the comfort zone and try some things that are going to be in your patient's best interest. So I want to talk just for a minute about this healthcare provider. So I think that that is something really that our industry, we've really got to step into this role, and it's a lot more fun to be a hygienist as a healthcare provider than it is to be a hygienist in the prophy trap. And I've done both, for the record. And I feel like I much more enjoy and get a lot more fulfillment out of being able to really use my mind and really look at patients as individuals and really assess their risk and really look at all of these layers of the diagnostic process and be a colleague with my doctor. And so this is something, and Danny's very familiar with this book and with the Bale-Deneen method. These are two individuals that we follow at Inspired Hygiene and study their work, and they're really bringing the awareness to the medical industry and also the dental industry, actually, how inflammation is one of the primary root causes of heart attack, stroke, and type 2 diabetes. And so I want to highlight their book here, and one of the things that Amy Dunning talks about in here are the red flags. And so I have a little exercise for you all to do. And so I'm going to call out a few of these red flags, and this comes straight from her website, which is the Heart Attack and Stroke Prevention Center, Amy Dunning. And I'm going to call out some of these, and these are risk factors for heart attack, stroke, and type 2 diabetes. And every time I call out one of these, and you've ever had a patient with this, I'd like for you to just put a little tick mark, by on your paper, okay? So personal or family history of cardiovascular disease, personal or family history of heart attacks, stroke, or type 2 diabetes, elevated cholesterol and elevated blood glucose levels, nicotine use in any form, diabetes, gestational diabetes and high blood pressure during pregnancy, high blood pressure, abdominal obesity, periodontal disease, rheumatoid arthritis, migraine headaches, psoriasis, and the list goes on. There are about 23 things on here. So I called out 12 items, and I'd love for you to just count the tick marks you made. When we do this in live courses, I share this, and almost always out of the 23, people will say, oh yeah, I've had patients with at least 20 or 21 of these items. So these are things that you're seeing every single day, and these are all red flag risk factors for heart attack, stroke, and type 2 diabetes. And other things like polycystic ovaries. I didn't know that was a risk factor. I mean, some of these things really surprised me. Some are very obvious, but some of them also really surprised me. So this is just a link to where you can get this red flags list. I think this is really helpful. And we've even had some teams that laminate this, and they use this as a kind of a diagnostic or communication tool with their patients. As we're looking at these and kind of checking off all of these multiples. And what we know is that if they've got multiple risk factors, that they build on each other, and they create this very heavy inflammatory burden. So it's important for us to remember that it takes two things, right, for an infection to occur. One is a susceptible host, and then the other is bacteria. So these two things are required, right? So these two lovely ladies, this is Kim Miller here on the left, and this is Jamie Marbeau, and they are two of our lead hygiene coaches here at Inspired Hygiene. And what the AAP studies have shown us is that the difference in severity between Kim's inflammatory response and Jamie's, and the difference in their severity of periodontal disease, 50% of that difference is based on genetics, right? Based on something that they can never change. And so I put this here just so that we're really looking at our patients' overall risk factors as part of that layering of the diagnosis, and all in an effort just to create awareness around how maybe we don't, what we're seeing, right, in our patients clinically, that's not the whole picture, right? There's a lot more going on there, and it's time for us to really recognize that and address our patients as individuals. This was a study that was done that was really revealing, and it showed how, I think there were 30,000 individuals or 30,000 different cases that were researched here and investigated here, and they showed, you know, time after time, reduction in some of these same conditions that we just mentioned, reduction in hospital admissions and reduction in lower annual medical costs. So it just says, you know, patients that have had a history of stroke, if their periodontal disease is treated, it's almost a $6,000 reduction in their annual medical costs. So there's some connection there. And so my effort in all of this is to help you create an imbalance where the value of the treatment that you're providing far, far outweighs the cost. You know, sometimes we get stuck in that. We get stuck in the cost piece, and it sometimes holds us back from what it is that we're recommending to our patients. And you know, I ask the question, don't you think that if you were able to reduce your patient's risk for heart attack and stroke, don't you think that that would be worth way more than the cost of that therapy? And always the answer is yes, right? So the value must always outweigh the cost. And sometimes we really have to look at that and figure out where that value is and how it's in our patient's best interest.
Well, and when you say value, it's not inherent value. It's perceived value.
Mm-hmm.
But I think the point too is that we, or the hygienists, have got to believe it first themselves.
Uh-huh.
And I think that, you know, sometimes just respectfully, the first place to look is at yourself.
Yeah.
You know, are you a good role model? Are you leading by example? And that's not just because it's an easier sell. It's also because it will truly prove to the individual just how valuable this is. And then even after that, it's still about perceptions. That's where the communication comes in. You know, I'll be speaking to some periodontists in a few days, and you know, who am I to talk to them about clinical protocols? So, you know, we talk about success in any endeavor, whether you're an engineer or a politician,
mm-hmm.
or a hygienist. You could be the best technician in the world. If you're not able to communicate in an effective way, your success is only going to take you so far.
Yep.
So I just wanted to make that point.
Yeah, yeah, absolutely. So the tangible and the intangible, right? So this is an example. Mm-hmm. This is an interesting example. Excuse me, and there are probably some of you that are doing some clinical laboratory testing, and this is just one that happens to come from a company called Oral DNA Labs. And this is
That's
actually
pretty tangible.
Yeah, very tangible. This is actually 2 tests on 2 different patients. And so what this is this is a salivary test that identifies certain pathogens that are present. So before Danny and I started, we were talking about, you know, that role of healthcare provider. And one of the things that dentists are asked a lot by physicians and by patients is, would you please give this patient clearance before they have heart surgery or before they have a hip replacement or some major surgery? Can you give them clearance to show us that there's not any active infection? And what we learned from that Beat the Heart Attack book that I just showed is there can be some subclinical infections that aren't actively visible. And these are the kinds of tests that can show that and show these really dangerous bacteria like the AA and the PG, right, these red complex bacteria. And what this shows is you'll see this one says at the very top positive for 5 pathogenic bacteria that are reported above the threshold, right? So this threshold, this black line, is where we expect the body to be able to manage that level of bacteria, right? We're never going to have a bacteria or a biofilm-free environment, but we certainly can reduce those levels dramatically in the care and the adjuncts that we use. And then the second test is where it says result positive 6 pathogenic bacteria. So these are actually 2 different tests, But yet you see the same bacteria are present. The only one that's different is this TD, right? And some of these are at different levels. This is two different individuals that are showing very similar bacterial profiles, and this is a husband and a wife. And so I always find this fascinating, and if there's ever any question, and this is a couple that I know personally, and if there's ever any question about transference of periodontal bacteria and reinfection, this is just a great illustration that if you have those patients that aren't responding or aren't getting the result that you're expecting, it's not always about their home care. In 1991 when I graduated from hygiene school, it was just, if you're not getting the great result, then it's the patient's fault, right? They're not doing their home care. And that's not always the case. Sometimes patients have such a heavy inflammatory load that their body cannot get ahead of this, and they need additional tools, whether that be antibiotics or non-surgical therapy or whatever it is. And sometimes they have situations that are constantly putting them at risk and introducing those pathogens. So just an interesting little thing that I always find is of interest to folks. So it's important to be calibrated, right? Getting on the same page. These are some photos of some of our clients, and Kim working with the team here on some ultrasonics instrumentation and really getting calibrated and having a common philosophy. And we even teach, a common way of enrolling. This is something that we call the 3 Ps, where including the patient in their diagnostic process, it builds that perceived value, right? They understand when we prep them and we tell them ahead of time, okay, this is what you're going to listen out for. 1 to 3 is typically normal and healthy gums don't bleed. And then if we're calling out all the numbers when we're doing the perio exam and they hear bleeding and they hear 4s and 5s and 6s, then all of a sudden they're coming alongside of us rather than us doing that whole exam in silence, right? The patient hears health versus disease, and then we can present that evidence. We can print that perio chart out on color and show them those areas of infection. We can take a picture of the bleeding and show them that. We can use whatever other types of patient ed that you have found effective, and we find that this very simple process of the 3 Ps can dramatically increase case acceptance for periotherapy because the patients are just being brought alongside. And the same thing can be applied with restorative too, right? We can tell them what it is we're taking a photo of, take the photo and show them, and then give them the problem and the solution. We're going to talk about that in just a moment. So the bottom line is, you may never know what results come out of our actions, but if you do nothing, there will be no results. So a lot of times, the reduction in risk of heart attack and stroke and type 2 diabetes is invisible to us. That's that perceived value. That's the intangible. But if we do nothing, then we know we have no chance of impacting our patients that way. And really and truly, our patients don't know how well we're taking care of them unless we tell them. So when you're doing an oral cancer exam, tell the patients what it is that you're doing, not in a scary way, but just, tell them what it is that you're looking at. Tell them, why am I so careful to examine your gums? You have diabetes. These two things are completely related, and just really educate them. And that can be done while you're scaling. It doesn't have to be a 10-minute conversation that takes up a ton of time. So I would ask you to kind of think about just this, when we talk about the perio piece, what do you see as the potential here? Where do you see that you might have some potential to refine what's happening in your practice now? And maybe jot that down. And then if you address that one item, so it's one thing, maybe it's charting bleeding. We're going to start charting bleeding so we can refine that. What is the return for your patients and your providers in your practice? All right, so one of the things we talked about was the 60% of restorative enrolled in out of hygiene. And so, if your goal is $100,000 in restorative, then $60K, right, should be coming from hygiene, should be enrolled in hygiene. And this is a team effort. We talked about that. between the dentist and the hygienist. And this is an example of one of our clients, right? You've got 16 days a month, right? So if you take that 60K, divided by those 16 days a month, you come up with a very reasonable number, right? This is very doable when you've got a whole team that is presenting treatment. And so set yourself a goal. Is this your goal per day of treatment that's going to be presented? And then what is our case acceptance on that? Maybe if you say our case acceptance is 50%, then we've got to adjust our goal to make sure that we're presenting the amount that we need to increase. And so let's talk a little bit about what that takes. So this is my hygiene school graduating class. This is me right here. I had a lot more hair back then. But we had 3 hours for an appointment, right? We had 3 hours to see one patient. And one of the things for the first hour that they expected us to do was really observe and make notes. Observe and make notes. And then one of the other things that they expected us to do, like typically in the last hour of that, was educate. So for some reason, once we get out into the real world, a lot of times we get, we develop this, I call it the I'm not supposed to diagnose syndrome, right? And so a lot of times dentists will ask us, they'll say, how do I get my hygienist to help me more with teeing up restorative and making this doctor exam more efficient? And I say, well, one of the reasons is that hygienists are reluctant to do that is because we've always been told we're not supposed to diagnose. But remember, back when you were in hygiene school, you were developing that skill of seeing and noting, right, of observing and of educating. So that's all it is. Yes, the doctor is going to make the final diagnosis, and we're all clear on that. But hygienists, and assistants too, you absolutely have the skill, and it is absolutely appropriate for you to be pre-diagnosing and cooperatively diagnosing with your doctor. And so don't let this, I'm not supposed to diagnose, stop you. And then the other thing that we find is that maybe the team just hasn't had the opportunity to really develop a real deep knowledge of the doctor's treatment philosophy. I use this image of this beautiful house, and I say, imagine you're in your hygiene operatory and you're down here at the beginning of this path. And the doctor's chair, the doctor's operatory is, this front door. And so our ultimate ideal is for the patient to say yes to treatment and to walk through this front door and to be in the doctor's operatory receiving that treatment that's in their best interest. And so there are a lot of different steps along this path, right? One of them is establishing the problem, right? Taking a photo and educating the patient. And some hygienists might leave the patient right here on this first step, and then the doctor has to come out of his or her front door and walk all the way down this path and get the patient and then take them all the way back to the front door. And that takes a lot of time. So one way you can create more efficiency in the doctor exam is bringing that patient further down the diagnostic path. And I ask doctors this all the time. The other piece of this is, so it's overcoming that I'm not supposed to diagnose, knowing that you are absolutely capable of observing and noting and educating and sharing with your patients what you see. 2 is the knowledge. We're going to get to that in a second. And 3 is the permission. So doctors, you've got to explicitly give your team permission to co-diagnose and tell them how far do you want them to take these patients down that diagnostic path. Do you want them to take them to the problem and then you offer the solution? Or like one doctor told me, he said, I want the patient to be ringing that front doorbell. So he obviously wanted the hygienist to take those patients as far down that diagnostic path as possible. And that takes some practice, and it takes what we call case review, right? This is a time when you're spending some time together with your team. That's what this team is doing here in this photo. And doctors reviewing treatment philosophy, reviewing charts. Team is creating a mock treatment plan, and then they're all reviewing it together. And so start with obvious cases like this. Start with something that's really simple and obvious. And, team, what would your doctor do with this? What would your doctor do? and get really clear on that, right? Would she do a full coverage crown? Would she do an onlay? Why? You know, what do you see here? You know, even start with the diagnostic piece of this. What do you see here? And then go to something that's more subtle. You know, what do you see here? And just look at that as a team and really get calibrated. And then this is something that doctor that I worked with for years, Dr. Chris Bowman, I have to give him so much credit for just so many things that I've learned. And he taught me this. Doctors, one of the most valuable things that you can do is take photos during your prep. Because we never get to see, you and the assistants get to see the inside of these teeth, but the business team and the hygienist, we never see this. And this builds so much value for recommending restorative, and also really helps educate the patient, the team to your clinical treatment philosophy. So I encourage you to really do that and share those regularly. So just put the case together like this, you know, and do this once a month with a couple cases. You know, have the team say, you know, what do you see in each quadrant? What are the problems that you see? Which section do you think is the most urgent? And what would I recommend as the doctor? What would I recommend? And just have your team come up with a treatment plan and see how close or how far away you are. And this is not a right or wrong. This is an opportunity for learning. So don't be afraid, team, you know, to ask questions and to say, okay, so why? I don't understand. Why would you do an onlay there instead of a full coverage crown? I mean, we go through this kind of thing with our clients all the time, and it's so revealing. We were just in a practice last week, and one of the assistants, she'd been an assistant for 15 years, 15 or 20 years. She'd worked with this doctor for probably 5 years, and I assumed that she, you know, probably had a very deep knowledge of his treatment philosophy. And when it came down to it, she said, you know what, I worked in Perio for 15 years before I came here, and so I didn't get to learn all of this. And I've learned a lot since I've been here, but we've never had time to really sit down and talk about why you do one procedure over the other. So no matter how long-term your team is, you will learn something, and something will be revealed in this exercise. So really recommend that, right? So just, you know, look at these obvious cases and then look at things that are more subtle. And the other thing I would encourage you to do is when you go through those cases, look at the whole big picture, right? Remember we talked about their medical history. So start with their medical history. What are we seeing there? Look at Perio. Look at their x-rays. Look at the chart notes. You know, look at their photos. Look at the tissue. What do you see? Like, look at the whole big picture as you're creating these treatment plans. So again, I would ask you, like, where do you feel like you have some potential to grow here in this restorative co-diagnosis piece? And where might that create a return? You know, certainly it's a return for patients when both providers are on the same page. And hygienists, for you, you know, this creates it's fun. It's a lot more interesting, right, than just scaling teeth when you can really become a colleague. And it's going to create a way more efficient doctor exam. You're going to have to wait less for doctor exams because doctor doesn't feel like it's going to take a long time and he has to start from scratch, you know, with every exam. And then obviously for the practice, it's going to help you, you know, be productive. So let's look, before we wrap up here, let's look at this open time issue. And this is something that, you know, a whole day could be spent on this alone. But I just want to give you a couple tips here with regards to this. And a lot of practices are dealing with either what we call ghost town or Grand Central, right? So, and our goal is to find the sweet spot between these two. A lot of times they're tumbleweeds rolling through the halls and everybody's trying to look busy, or there's so many patients coming in and out of the practice that we're maybe squeezing appointments, and maybe that's affecting that 20 minutes. And so we really love to help teams work and get closer to that sweet spot, whether it be, you know, increasing demand for patient appointments through high-level care, through reactivation, or whether it is really blocking time for that high-level care in a really, really busy practice. And so there are pros and cons to both of these things, right? What we see in when there's a lot of open time is that can really become that can affect morale in the whole practice, because again, everybody's trying to look busy You know, they're wondering, doctors wondering, what's everybody doing? Why don't we have any patients? And it can really affect everybody. And then, like I said, with Grand Central, a lot of times the knee-jerk reaction to accommodate patients or to increase production is just to shorten appointment time. And we find most often what goes out are those diagnostic pieces of the hygiene visit. And so the department might be busier and they might be producing more, but it might not really be profitable, and it might not be driving restorative as well into the doctor's operatory. So it's important to look at these things and see, you know, where are you? So when we talk about open time, this is really how we measure it. We look at open hours, so the time where you could have scheduled a patient but you did not, right? This doesn't include team meetings or things like that, but where could we have seen a patient and there was no patient there to be seen, divided by the number of available hours for patient care, and that's going to get you your open time. Remember, we talked about 10% really being the top end of that as the ideal. You know, Linda Miles says 3 to 5% is just life, right? Just things that are going to happen. And what we notice is when we see over 20% open time, that very often indicates an imbalance in capacity. So perhaps there's a lot more hygiene time available than you have demand for care. So that doesn't necessarily mean you have to cut hygiene days, but it means you got to really look at how can we increase demand. Is that reactivation? Is it marketing? Is it looking at your hygiene services and creating more demand by offering, you know, more therapy? So, but that's something that's interesting. Yeah.
I'm sorry, I'd like to just, and it may be a dumb question, actually, maybe two dumb questions. One, when you're measuring available time, it's got to be over a given period of time.
Oh, yes,
like,
good question.
You're not suggesting that every day they have 10% available. And my second question, which maybe, you know, we can all determine just how dumb it is the idea that as you reach 100%, whatever you know, capacity you set,
yes,
as you begin to approach 100, you just say, okay, well, now that we don't have any more availability, we need to establish more. And is that primarily, because this is very close to, you know, what I do,
yes,
to accommodate new patients, because new patients are the least likely to wait, or you're just talking about you know, current and new patients just for hygiene care?
Okay, so answer to the first question is we typically look at this on a month-to-month basis and measure it that way.
Okay.
However, you probably could do it each day. You know, if you have one patient out of an 8-hour day, then that's probably going to get pretty close to, you know, your 10%. So, but I would say that it's easiest to measure this over a month. And sometimes you have to go back and kind of count up, you know, here are the hours that we were available to work and here were the open slots that we had, and run these numbers that way. There are some ways to do it with software. I found that to be just a super straightforward, very accurate way to do it. Okay, and then your question is, I think that is a question that would need to be pulled apart into a couple different sections, and I would say that what we hope and what you probably teach with marketing is we want to be able to have capacity a little bit before we need it, right? So we want to have
yep.
Yeah.
You have to have the inventory. You have to build it, and then they actually will come. And more and more, it's to the point where people don't really feel that they should have to take their child out of school or miss work just quote, you know, their prophy visit.
Yeah. So you do. We just actually today I was on a call with one of our coaches and one of our clients, and they're very nervous about blocking time in their schedule. They have capacity to grow. They have their second hygienist can add another day, and they haven't filled that yet. And we have advised them to block the time for their new patients because they want to get to, they have about 14 new patients a month now. They want to get to about 24. They're about to move into a new facility that's going to be very visible. And so now we're looking out, right, several months ahead. And we're advising them to block the schedule, and they're really nervous about it. And I said, okay, let's just look at the next month. When is the next time that you can get a new patient in? So they had 4 available slots in the next month to get new patients in. Well, they don't even have enough capacity to see the existing number they have now. So, and now things will open up and things will change, but you want to be able to get those new patients in within a week, 2 at the most. And so you've got to reserve that, and then you've got to do something about it, right? It can't just be we build it and then we kind of sit here and wait and there are crickets. It's like we build it, they will come if we do something. And so the same thing is true for reserving time for periotherapy. You've got to block off that time. Really, even if you have open time on your schedule, you still should be blocking for perio, because it's a mindset thing. All of a sudden it triggers you to think, oh right, we got to be doing something, diagnosing, to fill into those blocks. So, we've had clients that have hired a 4th hygienist and then called us and said, okay, now we have all this open time, what do we do? And but they were willing to, they knew that it was going to take some time to fill the capacity, and then they tweaked their system. They had never been able to do periotherapy before because they had nowhere on their schedule to put it. So now all of a sudden they had this capacity, and then we helped give them the tools to now fill this capacity, now create the demand, because of you can now present this higher level care.
But the first step is to, commit to take that leap of faith.
Yes.
To expand the availability.
Yeah, it is. And again, that's something that all business owners face when you're building your team, right? Is you've got to have a little more capacity than you need right now in order to grow.
Yeah. And it's easier if you have someone that's willing to work more hours. They want the hours. But
well, that's the ideal.
You get to the point,
right.
Yeah, right. But then at some point you're going to have to make that
commitment.
It's a stair-step function. It's not a continuous function. You've got to recruit and hire somebody.
Right. So this team was fortunate,
leap.
right, because they said they had someone that was willing to come on for 3 days and grow into 4 days. But they had to commit the 3 days to her. So So with regards to reactivation, just a couple simple tips as we wrap up is, make it personal. One of the gals that works with us, Emmy, she's got such a great way. When she makes reactivation calls, she's got a big smile on her face. A lot of people don't like to do those calls, but she loves it, and she's found a way to make it fun. And she says, you know what, doctor asked me to call you personally. We've missed seeing you, and we love to take care of you. Tell me, how have you been? And then this team created this really fun reactivation card. This is not the white postcard that gets lost in all of the junk mail. This is an oversized, personalized postcard of their hygienist. We would jump for joy to see you. This is something that is going to stand out when it shows up in the mailbox. And so I was really proud of them when they did this. This is one of our clients. This is actually the team that hired the 4th hygienist and built into the capacity, and they did a great job with it. So it's great. Important. Yeah, it's important for everybody to be on the same page and to have the same vision of where do you want to go. This is one of our amazing client teams, and we have a great time when we're together with them. You can see they have Mardi Gras beads, and we play a little bit, and we make learning really fun, and we ask them, a year from now, so if we're here a year, if we meet again here a year from now today, what has to have happened, in your practice for you to feel good about the progress? And that's something that if you don't take time to write that down now, I would really encourage you to do that. Is to, what would need to have happened, and then look at what is the one thing, what's the biggest return on hygiene that you thought of through the whole course. Like, what is the one thing that you thought, gosh, that would really make a difference? And just jot that down. And here's the deal. It's courage, right? It takes courage to go from where you are now to where you want to be. And someone taught me this one time, it's called crossing the panic point, right? And the willingness to cross that panic point, that scary get out of our comfort zone point, is what separates the successful and gets you all those fun things that are outside of your comfort zone, right, from the mediocre and just kind of staying in that prophy trap. And so, you know, you can go from being burnt out to being fired up, but it does take some new beliefs and some new actions. And that's what we love to do. This is the Inspired Hygiene team. I'm so thankful to work with these ladies. And we like to hold your hand, you know, as you're going through crossing that panic point. And what we find is that every time you do it, it gets a little bit easier, right, Danny? It's just like speaking. You know, in the very beginning, it's really scary. And then the more you do it, the easier it gets. And it's still a little bit scary from time to time, right?
Yeah. And one thing to keep in mind is you can always go back. But, you know, the quintessential example for me was going from being an employee to being self-employed. And you, some people, you know, I like to climb mountains, and so,
yeah.
But I was much more scared of starting my own business than I ever was on any mountain, because, you know, that's like you're completely free now to go out of business. When people say, "Oh, don't you love the freedom?" Yeah, I do love the freedom, but you're also free to, you know, to lose your shirt really quickly.
Yeah.
But you can always go back, but you don't know what it looks like from the other side until you step over that chasm, you know?
Yeah, yeah. Yeah, and it's worth it. And you don't have to.
It's worth it.
It doesn't have to be, and it always doesn't have to be a huge chasm, right? It can be a baby step. So sometimes the first point, that first panic point, is a baby step, and that's okay, right? It's taking that little baby step out of the comfort zone, and then you get some confidence, and then you try it again, and maybe next time it's a little bigger step.
Yep.
So Danny, this is what we
wanted
to, this is what we wanted to share with everybody this evening. Is there anything that you wanted to say about this, or do you want me to?
Well, I do.
Okay.
Yes, well, I want to thank you for offering your Return on Hygiene book. I read it. It was a very enjoyable read. It opened my eyes to what I took a lot of pearls from it. The consistency of practice philosophies between the hygiene team and the practitioner, I think, was really important to me. And we talked about perceptions a little bit earlier, and I was reminded of it when you said that you showed the house with the steps, and one doctor says, "I want him to ring the doorbell," and that may well be, but it's really important that the doctor communicate that effectively to the team.
Absolutely.
So the team knows it's okay to ring the doorbell.
Yes.
Right?
Yes.
And that's just one of a number of great points and advice that I got from your book. And I appreciate you offering it. I don't know if you have a code up here you want to share, but I talked to Rachel, and she agreed to offer this book without any cost at all to our attendees. And she was even going to cover the shipping and handling. I just want to tell you all that that's not possible, not because she can't afford to absorb the shipping and handling, but we happen to work on a platform, a shopping cart called Infusionsoft, and it will not let you take orders if people don't pay something. And so I hope it's not too much of a leap based on what you just heard and what this book promises to fork over the $3.95 it's going to take in order for you to own one of these books. And we will, when we send you the information to apply for your CE and send you a link to the recording of this webcast, also include you with a handy-dandy link for going to the shopping cart. But in the event that you don't get around to that, or for those of you who are motivated right now, I thought I'd ask Rachel if she would just take a minute to kind of walk us through how to get to the point on her website where you can enter this code, which is for AIM Dental Marketing, AIM ROH, AIM Return on Hygiene, and then the regular fee, which is what, $19.95, Rachel?
Yeah, so let's just take a look real quick, Danny. Thank you for the opportunity to do that. So if you just go to inspiredhygiene.com, you go to our store right here, and then you scroll down a bit, and here you'll find our book. So if you just click here, then you'll enter all your information. You'll see that the price of the book is $19.95. You'll enter all your info, your shipping info, and all that. And then down here in all caps, you'll put AIM, R-O-H, and then if you hit apply, you'll see that it changes it just to the shipping, which is $3.95. So we're thrilled to offer that. And here's the deal, too. you don't just get the book, which is a good quick read with a lot of worksheets. There's worksheets in here. We also offer the chance for you to get the full page worksheets. You could do this, a lot of these with your team during team meetings. But the other thing that you get too is a phone call. I'd be happy to chat with you. You know, once you've read the book or you had some questions about that, I'd love to offer just that complimentary time to chat and see how we might be able to be of service to you. So let's go back. I know, Danny, we want to go back to maybe some questions.
Yeah, let's get some questions.
And we'll
Absolutely.
leave the code up here for a few minutes. Yeah.
Yeah, great. Well, thanks, again, for delivering, making me look good by inviting you to speak. And I think it's self-evident. You're a veteran at this, and your expertise and more equally the passion and commitment to not just financial success, but fulfillment. Shines through loud and clear.
Well, thank you. Thank you.
I love you for that, and I thank you for that.
Thank you.
Okay. Question 1, how do I set a commission rate so that it's in line with this 3-to-1 profitability ratio?
Yes, great question. We get that. So doctors will say, okay, I'm considering some type of compensation model that involves commission. And so how do I do all that I can to ensure that it falls within that 3-to-1 rate? And so we've seen all across the board from, hourly employees with no incentive, all the way to full commission, 100% commission. And so what we've seen work really well is something that's kind of in the middle, which is a base plus commission. And so that base, with risk comes reward, right? So one of the things, we talked about in the beginning was the dentist and the risk that the dentist takes in starting the business, and that the greater the risk, we hope the greater the reward. And so one of the things that we recommend with this base is that the base may be a little bit lower than what the market rate, let's say for a hygienist hourly rate is. However, once that hygienist hits that 3-to-1, then a commission rate can kick in that can take that hygienist way above the going market rate. So if, for example, let's say, the hygienist's rate was $30 an hour, once he or she hits that 3-to-1, which would be $90 an hour in net production, then what you can do is you can set a commission rate that you'll share a percentage of anything that's over that. So they hit the 3-to-1, you've now confirmed that you have hit that first point of profitability, and then anything that's produced over that $90 an hour, then a portion of that can be shared with the hygienist, and you'll determine what that is. I mean, that can be it can be a range from, I would say, 15 to 25%, somewhere along that line. And so that's one of the things that we've seen well, and that can ensure that you're in that 3-to-1 profitability and still able to share some of that with the hygienist.
Yeah, what's great about it, it's a very tangible goal, too, for the hygienist. It's like as soon as you hit this, and this is the justification for it, then we're off to the races. And, or throw another metaphor or a cliche, the sky's the limit.
That's right. Yeah.
Right. Okay, next question. I'm nervous about, this is a good one. I'm nervous about presenting perio treatment to patients I've been seeing for a long time when I haven't mentioned it in the past. What's the best way? How do you suggest to talk to them about this this new paradigm, I guess?
Yes, we get this question. This is probably the #1 question with clients that we work with. So what we know is that 9 times or more out of 10, the hygienist, if they're presenting periotherapy today, they've talked to this patient about something in the past, about flossing more because their gums are bleeding, or they've talked to them, they've shortened their interval, right, between visits because they're having bleeding and pocket depths that are greater than 3 millimeters. They've done something. They've had some kind of conversation with this patient. So most of the time, it's not really coming out of the blue. They may not have presented periotherapy, but they've talked to them about something. So I always say, go back and look in the notes. If it was you, go back and look in your notes. If they saw a previous hygienist, go back and see what did they talk to them about, and then build on that. And you can say, we've talked about this. Remember, we've talked about the bleeding gums. you were going to work more on flossing, we had you come in more frequently, and here's the thing is, your body's not responding the way we had hoped. We've tried all these different very conservative methods. Your body's not healing and responding the way we had hoped, so it's time to do something different.
Yep,
So
and it's all in how it's presented.
Oh, right, exactly.
Yeah, right. Because, I can see, and the mindset is like, oh, well, how am I going to basically upsell people? We believe we're not doing this for the money. We're doing this because we know this is the best care and this is standard of care, but we know we're afraid of how we're going to be perceived. Well, the first thing to do is get your head right, and then work on some communications where instead of the "I'm sorry to have to tell you this" approach, it's, as you suggest, Rachel, it's remember when we discussed this, well, I've got good news.
Right.
And then you present something. Yeah, we have a solution now. And the other way to explain it is that, hey, we live in a rapidly changing world. There's new technology that comes along. We've actually been monitoring certain technology for a while, but we don't want to be the first adopters because we wanted to make sure that the efficacy was demonstrated. And so we deploy a conservative approach in our practice, but now we've seen enough to know that it's time to present this. Something along those lines.
Yeah, absolutely. And I think that our bodies are rapidly changing too, right? I mean, you can go to the doctor one year and have high blood pressure, or not have high blood pressure, and go the next year and you do. So for some reason in dentistry we think everything should be static and that we should have told them this 10 years ago. Well, they may not have presented this way 10 years ago.
Well, and the effects are cumulative anyway.
Absolutely.
When you leave something alone, you stay below that threshold, you're not healthy, you're just non-sick for a while.
But you're not getting any better. So that's the other thing is sometimes hygienists will say, well, they're not getting any worse. Well, they're also not getting any better. And if they've got chronic bleeding gums, that is an inflammatory burden that patient shouldn't have to carry. And it should be their choice to do something about it or not.
That's right. We shouldn't make assumptions or decisions for our patients. We should give them enough to empower them to make an informed decision about their own care. You're right.
Yep.
Can you explain how it benefits the hygienist to recommend more perio treatment? If I can treat it in a prophy, it just seems like more work for me to explain the treatment and schedule another appointment.
Yeah, so some hygienists say, well, I can just take care of that in the prophy. Well, what we find is, remember that 20-20-20 we talked about in the past, is if you're spending much more than 20 minutes on that scaling and polishing, then that patient probably needs something other than a prophy. And so what we find is, when the hygienists are spending 30, 40, 45 minutes, then the diagnostics is going out the window. So it's almost like when we take the time to really create the diagnosis with the doctor, right, and have doctor confirm the diagnosis, and then have that patient in an appropriate path of care, then all of a sudden when these patients show up for a perio maintenance or a prophy, they're a prophy, or they're not scaling, they're not undercover scaling root planing. That's something we hear with our clients too, is they say, you know what, now when I have a patient that shows up for a prophy, it's actually a prophy. It's not scaling root planing disguised as a prophy. So it actually ends up making a lower stress level for the hygienist and allowing them more time to talk about restorative, to do these other things, because they've gotten those patients that need therapy that were taking so long in a prophy, gotten them into the appropriate care and gotten them healthy.
Yeah, and a better sense of satisfaction about what you're doing. I think Chris Kammer in his presentations refers to it as polishing the disease, too.
Wow, that's a good one. Polishing the disease. Yeah, and absolutely a higher level of satisfaction, because you're actually getting somewhere, right? When we keep seeing these patients over and over and they're bleeding, we feel like, gosh, I don't know what else to do. Like, I'm not getting anywhere. So if we stop and we get them into therapy, they still might they still might not always get better, but now at least we've begun the conversation and we can say, okay, is there another adjunct we need to use? Is it time to refer? Is there something else going on with your body? You know, we've done this to dramatically reduce these biofilm and eliminate this infection. And there's still areas of bleeding. Like, what else could be it helps us uncover what maybe the real problem is.
Mm-hmm. Yeah, absolutely. Okay, we got time for really only one more question. It seems like the doctor exam takes a huge amount of time in my appointment. What's the best way to make this more efficient?
Mm-hmm. So I alluded to that a bit when we talked about the path, right? So if we can get really clear on the treatment philosophy and get really knowledgeable of our doctor's treatment philosophy, and then we can do that data collection before we start scaling and take the photos, then, man, if you've got a photo up on your monitor when doctor walks in, then that should be doctor's cue that, okay, we've got things to talk about. Or if you hand doctor this printed Perio chart, we've got things to talk about. We've got to get down to business. Now, that doesn't mean that doctor can't connect and have, you know, that personal connection with the patient. And doctors sometimes doctors feel like they have to spend a lot of time in the hygiene room because the hygienists maybe haven't taken the patient as far down that path. The other is true where maybe the patients have done that and doctors are still repeating things, or maybe they're still spending too much time on the social. So talk about that and don't take it personal. You know, just say, hey doc, I want to support you. How can I help make the personal connection more efficient? And is there a cue word that I can give you that, you know, if it's time for us to talk about the teeth stuff and you're still talking about baseball, is there a cue word that I can give you to help you kind of realize it's time to move on? And a lot of times doctors will really appreciate that if we approach it in a way that's like, how can I help you? Because I know you want to get back to your operatory too, and we want to get, you just make this the best, most efficient exam. How can I help you? Here's a couple of things that I'm going to do. And then would it be okay if you shared with me maybe a cue word that I can help you with that? And just, you know, approach it that way.
That's great advice. Okay, well, now, and there were some questions about CDT codes and whatnot, but we'll get those to Rachel, and I'm sure she'll be happy to respond to you offline.
Sure.
At this point, I just, again, want to thank you very sincerely for the great presentation and the terrific offer to get your book without any cost. Can't see where anybody will regret that decision.
Well, my pleasure,
Yep, and thank you again. In a few days, you all will receive an email with instructions on how to receive your 1.5 hour of CE credit and to receive Rachel's book free of charge. I would like to ask you now to mark your calendars for our next webcast, which will be on Thursday, March 23rd at 6:30 p.m. Central Time, when our special guest presenter will be Perio Protect's perfect follow-up to Rachel's presentation. Their managing director, Dr. Tanya Dunlap, who will deliver the warm and fuzzy presentation entitled Kill 'em, Then Oxygenate 'em, a killer home care regimen to create a firm gingival foundation to support future patient care. Until then, this is Danny Bobrow, thanking you as always for your continued commitment to practice perfection, and thanking you once again, Rachel Wall.
Thank you. Thanks everybody for being with us.
Goodbye, everybody.